Evidence is the backbone of modern medicine, but whose evidence is it if key groups are missing? We're Sciana Cohort 7 Challenge Group Trust and Accessibility in Clinical Trials. Today, we're joined by Professor Jörg Meerpohl, Director of Cochrane, Germany, and the Institute for Evidence in Medicine in Freiburg, whose work helps turn research into reliable guidance. We're asking, how can evidence become not only rigorous, but truly representative?
I'm very glad that you could make it to our interview. And for the first question, I would like to ask, can you tell us about what brought you into the role you hold and what is involved in your role?
So my name is Jörg Meerpohl. I'm a trained pediatrician and pediatric hematologist and oncologist. I've been seeing patients for more than 10 years, but back in 2007, I started moving in the field of evidence-based healthcare and joined the team of the German Cochrane Center. Cochrane is an international organization that aims to develop systematic reviews of evidence. So basically what we do is that we systematically search the biomedical literature for clinical studies evaluating the same type of clinical questions, then quality assess these studies and synthesize the evidence with statistical methods. That's called a meta-analysis. And that gives us the possibility to have more power in our meta-analyses than in individual studies. And for that reason, because it's quality assessed, it's more powerful, it's often the basis for clinical guidelines. So if people talk about evidence-based guidelines, usually that is based on systematic reviews or Cochrane reviews. And that's where I work in now. I'm director of Cochrane, Germany, and also head of the Institute for Evidence in Medicine at the University of Freiburg.
From your perspective, if you look at the ecosystem of studies you are looking at, do you see like differences who is taking part in the studies or which kinds of population groups the studies include?
From my point of view, there are several elements to that. For one, I think obviously we see different study activities in different countries and legislations. Certainly there isn't equal study activity across the world. That has, I believe, partly to do with costs associated with conducting studies in certain regions or countries. And obviously it might be cheaper in some countries to do a study. Also kind of administrative, legal, ethical requirements. I think there are certain countries leading in study activities. I believe still it's the US, it's UK, it's China, I think has picked up quite a bit. Germany is probably somewhere in the middle field, and within the European Union, my understanding is that recently, in particular France and Spain have increased their study activities or have been successful in increasing their study activities. So it's certainly not equally distributed across the world. Hence, the population included in these studies varies because it's mostly participants from that region where the study is actually being conducted. Often it's a very well-described population of patients that is participating in studies, often not necessarily the small children and or the elderly people, not so much people with multimorbidity or multiple diseases, because that keeps the study population more homogeneous, which is important if you in particular look at effectiveness of a drug in the first instance.
If you look at these very selected populations, are there populations, not only the multimorbid, but for example, like gender or cultural or race or something like that, where you say, we are missing this data? If you look at the studies and you say, where are the gaps, for example?
What I certainly do recall from my clinical time being in pediatrics, we do lack studies on kids. Often it's not, I guess, worthwhile, sometimes even worthwhile for large pharmaceutical companies, and that's not to blame them, it's quite understandably from an economical point of view, to conduct a full study portfolio in children or even newborns once a drug has been approved for adults. So quite a bit of drug use in pediatrics is actually off license because drugs are not formally approved for pediatric use. And so I think that population certainly is missing in terms of gender or ethnic background and so on and so forth. I'm not absolutely sure. Still, I would believe that in particular over time, there has been a bit of a shift in which populations have been included in studies.
And in your experience, are there particular like disease areas or specialties where trial participation or studies are noticeably higher or lower? And if there are, do you know why?
My understanding is that, yes, there are areas where we do see a lot of study activities, for example, cardiology, oncology, and others, so kind of important main diseases, Volkskrankheiten, as we call them in Germany. That's often where we see a lot of study activity. I think for rare diseases, often we see fewer study activities. Again, I think this is in part quite understandable because there are fewer patients, but still, theoretically, it would be possible often for many of these rarer diseases to conduct appropriate studies. We might need at least multi-center, if not multinational studies. And the market for some of these drugs in these areas might not be as attractive for drug development or medical device development for that matter. Also, I think in public health and non-pharmaceutical interventions, we see often fewer studies because there is not potentially that attraction of a relevant market for an intervention. If it's, for example, hand washing or some other non-pharmaceutical interventions that don't produce a benefit because there's not much to produce. It's just the behavioral interventions, for example, physiotherapy, etc.
And earlier on, you mentioned that Spain is picking up on studies, at least. So let's keep it to the European Union area because the legislation is quite comparable. What are they doing we in Germany, for example, are not doing?
But from what I hear and understand, in part, one of the issues in Germany is that some of the administrative legal requirements and the implementation of these and adherence to these is quite complex. For one, it's the contractual arrangement that has not been standardized for a long time. From what I understand, there are activities going on now in trying to standardize contractual arrangements, for example, with pharmaceutical companies to make it more simple and more straightforward to come up with an arrangement. Same is true for data protection. There is quite a bit of variety in how data protection legislation is being interpreted across Germany. And ethic approval, again, I believe for multi-center studies, various ethical approval boards would need to look and approve a trial. And I think that has made it quite complex and cumbersome and time-consuming to plan and conduct a study in Germany. And again, from what I understand and hear, this has been much more streamlined in Spain and France recently, so that it's just more attractive and more straightforward to plan and get a study started in these countries. It's also my understanding that as part of the Medizinforschungsgesetz in Germany and other initiatives, and Germany is trying to follow that route and standardize, harmonize approaches to become more attractive as a country for conducting studies again.
Earlier in the interview, you said that you are doing meta-analysis. So you take many studies and look at them and try to compile the evidence. If you now see some countries participating more and some countries not, and if we look at that we are missing some parts in studies, how is this bias impacting public health or the outcome of the evidence generation?
So I'm not sure I would call that, if I understand the correct, bias, because it's, as we discussed earlier on, in some regions and or in some populations, studies might not be conducted or not be conducted to the same amount. So what we can use for our meta-analyses is just a set of studies that, for example, are conducted in high-income countries, but not so much in low-income countries.
Yes.
Okay. So in our kind of methodological thinking, we would distinguish that from bias, which bias implies that we are kind of deviating from the truth. And here it's more that there is, we call that indirectness. So we have evidence in another area, it might be a slightly different dose, could be different population, and we are interested actually in making a recommendation or having evidence for another population. So it's more that concept, we call it indirectness or applicability, transferability are other words being used. Sometimes we have to deal with the fact that we do have evidence in one population, might be region, might be age structure, might be disease status whatsoever, and not so much in another that we are actually very interested in. And that requires then some expert judgment, really, whether the available evidence can be equally transferred to another context, region, or subpopulation. And that often is quite difficult. But I think that is some uncertainty that we have to accept. Ideally, I agree, we would have, in particular, if there is good reason to believe that an intervention might work slightly differently in a different context or population, to conduct those studies, but that is often not the case or not possible, maybe also not feasible financially or for other reasons. And so it's that judgment that is required. Still, I believe, let's say if, for example, an intervention on drugs been developed, has been approved and tested in adults, now we want to apply them in children. But if it's perceived to be safe and effective for the kid's population, it would be used. Potentially, we would see some observational studies collecting evidence after the fact, which then could inform whether that initial judgment was hopefully correct or not, or whether we are actually seeing a lesser effectiveness or a higher harm potential whatsoever.
In your view, if you could change anything, what you would like to change most to get better evidence or to include study groups, for example. So what would be your setting to get better results?
The research community should try to find a reasonable, good balance between required administrative procedures, legal considerations to observe, to ensure really that studies are appropriately safe for the participants. I think that is absolutely high priority, and that includes data protection, etc. But at the same time, try to strike a balance that allows, that is not overcomplicated for people wanting to conduct studies, because we need to conduct these studies to inform medical practice. And it's not helpful if the threshold is so high in terms of requirements that people refrain from doing studies and just use drugs once they are approved in other populations without appropriately studying them. And so I think it's about the right balance, certainly participant, patient protection, but still in terms of, for example, standardization of contractual arrangement, etc. I think that ethic approval through one ethic board, I think these are very sensible approaches to try to make study planning and conduct more straightforward. While I fully understand that there are instances where randomization is not possible, so allocation to treatment groups, comparisons group by chance. For example, if you want to study an harmful exposure like smoking, obviously that wouldn't work. You can't randomize people to smoking or not smoking. But in many other instances, I think randomization is possible, in particular when we don't know whether one intervention is actually better than another one. And then from my point of view, it's even ethically appropriate and required to then randomize rather than just providing an intervention to patient and comparing, for example, this group to a historical cohort. Whenever possible, I think we should strive to randomize, because that just gives us the best protection against biases, to, as quickly as possible, fully understand whether an intervention is helpful or not, and what the limitations are. And I guess my third and final point might be that often we see, and we had discussed that and touched on that already, studies either randomized or non-randomized with a very described population, which doesn't necessarily reflect the true patient population that might receive that intervention in the future once approved or once available. And I think one approach here would be to think more about pragmatic trials, a term that is being reserved, or not reserved, but is being used for studies with fewer inclusion criteria, less strict. So trying to capture really the overall population that might be benefiting from a given intervention. That has also some challenges, obviously, but better reflects the intended use. And I think are also potentially easier to conduct or cheaper. And I think seeing more of these would be helpful.
Thank you very much. Do you have any questions at the moment for me or for our group?
I think what I find interesting is if you collate all this information from different stakeholders, and if a report or whatever comes out, or a summary, if that could be shared, I think that would be quite interesting for me.
Thank you very much. We will do that.